After having gastric sleeve, I immediately saw results. Before the surgery, I had lost 25 pounds, and after the surgery, I lost 105 within 9 months. As soon as I met Dr. Lynch, I knew he was the guy. The support that I received through the whole team at St. Clair, even down to the receptionist, everyone was on my side. It gave me the jump start that I needed to change my life.
Well, welcome to our first virtual weight loss seminar. I'm Dr. Lynch. I'm the bariatric surgeon here at St. Clair. We appreciate you all logging in to experience this with us. This is the first time we've tried this here. Given the coronavirus, we wanted to still give our patients and potential patients an opportunity to see us and to have these seminars. Since we can't have them in person, we thought we'd try this. So if we have some technical hiccups, just stick with us. But I think we're going to get this done and we're going to have a good time tonight. So I think the first thing I should do is introduce my team. The cornerstone of my program is Jessica Kofer. She's my bariatric coordinator. She's the circulator nurse in the operating room when you have your surgery. She'll be there at every appointment. She's there for all your follow-ups. She's your initial point of contact, and really I couldn't have this program without her. Lisa Deely is our dietitian. She's going to help us with your preoperative and your postoperative diet. She's going to help you with any of the food-related questions you have. She's going to help make sure that you stay on track with eating and food logging. She'll encourage you to exercise. She's very important to our program as well. We are an accredited program through the American College of Surgeons, and what that means is that the college came to our program. They looked at our outcomes. They looked at all our policies and procedures. We had outcomes that were acceptable to them. We have all the procedures in place that they think deems us a program worthy of accreditation. This is not something that every program gets. We're very proud of this, and I think it allows you to be assured that you're getting quality care. Well, so let's talk by talking about obesity. Obesity is a disease in which fat's accumulated to the extent that your health is impaired. It's widespread. It's caused by many factors. It's lifelong. It's progressive. It's life-threatening. And it's very costly to the healthcare system. If we're going to talk about obesity, I think the most important thing to do is to have a common language. I think if just talking about what your weight is, well, what does it matter if you weigh 190 pounds and you're 5'4" and I weigh 230 pounds and I'm 6'4"? Is that the same? So we need a common language, and the common language we use is called the body mass index. The body mass index is a ratio of how tall you are to how much that you weigh. For example, if you had a 5'4" female, a normal weight for her would be about 130 pounds. That puts her BMI at about 22. A normal BMI is between 20 and 25. If your BMI is above 25 to 30, then that's considered overweight. So that same 5'4" female would be about 150 pounds. If your BMI is above 30, then you're considered obese. Class 1 obesity is from 30 to 35, and again, that same 5'4" female, that's about 175 pounds. Class 2 obesity is from a BMI of 35 to 40, and that same 5'4" female would be 205 pounds. And Class 3 or morbid obesity is when your BMI is above 40. And if you think of our example of this 5'4" female, that's somebody who would weigh 234 pounds or about 100 pounds over what they should weigh. When we talk about bariatric surgery, we're talking about people with BMIs greater than 35. So how big is this problem? You're not alone. About 36% of the people in Round County are obese. The same for Morgan County, Bath County, Carter County. Somewhere between 35 and 40% of the people locally are obese. In Kentucky, that's 34.2% of the population is obese. That puts us 7th in the nation. And just to put that in perspective, for where we were at, say, 30 years ago. In 1990, only 12.7% of the population in this state were obese. And even then, we were 8th in the nation. So you can see that this problem has grown exponentially over the last 30 years. And to be honest, we don't know why it's grown so much. So what does obesity involve? Well, there's a lot of factors that influence. It's more than just, what you eat. There's certainly genetic factors. We don't necessarily have all of those figured out. Maybe in 30 years we will. But currently we don't know. We just know that there's probably some genetic influence to people's weight. There's environmental and behavioral factors, so kind of how you were raised. So were you raised eating a lot of snack cakes? Were you raised with celebrating every event with food? There's psychological reasons. If you think about why people eat, we should only eat because we're hungry. But how many times do you eat because you're happy or you're sad or you're celebrating something? There's how our body processes food. So physiologic reasons and metabolic reasons. We all have friends that can eat the same amount that we do and they don't seem to gain weight. I wish I could tell you that I knew the answer as to why that is, but we don't. We don't know the answer. Those people are just fortunate, I guess. So why can't we just lose weight? Why isn't it easier to lose weight? There's a theory called a metabolic setpoint theory. And what that means is if you think of your weight as sort of like the temperature in your thermostat, our body doesn't like to deviate from that temperature. And so what happens is as we start to lose weight through calorie restriction or dieting and exercise, our body reacts to that deviation from the set point. And just like if your house gets too hot, the air conditioning comes on, our body reacts to a deviation of our set point by increasing hormone expression. And what that does, it makes us hungry. And it makes us want to eat more. And the more we eat, the more weight we regain. I always say that one of the hardest things we ask patients to do is lose weight. I think if it was easy to lose weight, nobody would be overweight, for sure. So why does it matter? Why does it matter that we're overweight and we look different than other people? Well, if it was just how we looked, I think that would be one thing. But there's a lot of health conditions that are related to obesity. 80% of the people that have type 2 diabetes are obese. Hypertension is 6 times as likely in people that are obese. Osteoarthritis is 4 times as likely in people that are obese. Asthma is more common in people that are obese. Urinary stress incontinence, more common in people that are obese. Migraines, depression, more common in obese people. Obstructive sleep apnea is almost only a disease of people that are obese. It's these reasons that we know that we have to do something to improve the quality of people's lives. It's not just about what your weight is. So who are we talking about? When we talk about bariatric surgery, specifically the group that I'm talking to are people that have a BMI greater than 35, that have some of those obesity-related comorbidities that we were talking about. High blood pressure, obstructive sleep apnea, type 2 diabetes. If your BMI is above 40, it doesn't matter if you have any of those conditions. We know that a BMI of 40 is a red flag. And I always say it's the equivalent of going to your primary care doctor and having a blood pressure greater than 200. We all know that's bad. That's not going to hurt you that day, but we know long-term that's bad. A BMI greater than 40 is the same thing. It's a red flag. It tells us that something's going on in your body that if we don't fix it, things are going to start to go bad. So how do we lose weight? There's a lot of options. One is diet and exercise. And, like I said, if it was easy, I think everybody would just say, okay, I'm just going to diet and exercise and lose weight. But it's not easy. And, we've studied this. And when you look at diet and exercise alone, even under physician management, maybe 1 in 100 people can go from a morbid obese state to a normal weight. The average weight loss is about 1% at 5 years with diet and exercise alone. So those numbers are pretty discouraging. There's drug therapy, drugs like Adipex. If you look at people that have been on Adipex at 3 years, the average weight loss is about 10%. So if you're 100 pounds overweight and you lose 10%, that's about 10 pounds. So pretty modest weight loss. The other thing is when you stop taking that drug, people tend to gain that weight back. There's not good long-term data on staying on these drugs for years and years and years. And in my opinion, they're good for people that are modestly overweight, but not somebody who is morbidly obese. Now compare that to the outcomes that we see with surgery. With bariatric surgery, typically what we see is about 80% of the people will lose 80% of their excess body weight. So that means if you're 100 pounds overweight, about 80% of the people will lose about 80 pounds. Some will lose more, some won't lose as much. But most people lose about 80% of their excess body weight. And that's sustained. We've looked at sleeve gastrectomies out 15 years. And even at 15 years, the average weight regain is about 10 pounds. And so 10 pounds, if you lost 100 pounds, or I'm sorry, 10%. If you look at, you lost 100 pounds initially, at 15 years, the average weight regains about 10 pounds. So that's not much. It's not perfect, but it's not much. So what is a sleeve gastrectomy? That's the operation that I do here at St. Clair. It's an effective tool for helping you lose weight. And really what it is where we take a majority of your stomach out. So about 80 to 90% of your stomach will be removed. And we change your stomach from a big empty bag into something that's kind of shaped like a banana. It's called a sleeve because I want you to think of it as like a shirt sleeve. That's kind of what your stomach looks like afterwards. And that excised portion of your stomach is removed and it's irreversible. We can't put it back in there. Well, so what does that do? What does it do that you have a smaller stomach now? Well, when we eat and our stomach stretches, it sends a signal to our brain to tell us that we're full. It's called the satiety signal. When you get a satiety signal, it tells you that you don't need to eat anymore. Think of when you eat Thanksgiving dinner, for example. When you eat Thanksgiving dinner, at the end of dinner, and when you're completely full, food doesn't sound that good. We crave that satiety signal. When you have a sleeve gastrectomy and your stomach's very small, it doesn't take much food to signal that satiety signal. If that satiety signal comes after just a few bites of food, then you're not going to consume a lot of calories. If you don't consume a lot of calories, you're going to lose weight. So how do we do it? Well, we do it minimally invasively, and that means that we do it with cameras. We usually make 4 incisions. 3 of the incisions are less than a centimeter. 1 of the incisions is about 2 centimeters long, or about an inch. And that's the incision that we pull your stomach out of. The operation takes about an hour, and usually you stay overnight in the hospital and you go home the next day. So why do we do this? Like I said, if it was just about weight loss, I don't think I would be very excited about doing this surgery, but it's more than that. And when you look at this chart of obesity-related comorbidities, we see that in about half of the people that have this operation done, half of the people with type 2 diabetes, half of the people with high blood pressure, half of the people with high cholesterol, and half of the people with obstructive sleep apnea will see their disease resolve. So that means no more medicine, no more CPAP. Almost everyone sees improvement in these conditions, but over half are going to see these conditions resolve completely, and that's exciting. There's very few things in medicine that I feel like we can actually cure, and this is a cure for a lot of these comorbidities. Well, just like with any surgery, whether you're getting your tonsils out or whether you're having a sleeve gastrectomy, there's risks with surgery. And then the risk that I talk about the most is called the staple line leak. And so what happens with a staple line leak is where we staple off your stomach, those staples can come apart. Now that's a very rare complication. That happens maybe 1 out of 100 to 1 out of every 200 cases. But when that happens, you can spill intestinal contents into your abdomen, and that can make you very sick. It can require a second surgery. The way we prevent that is we're very strict about a preoperative diet, and that acts to shrink your liver down. And if your liver's smaller, it's easier to see, which makes the operation easier to perform. By far, much more common is dehydration. It's the most common complication associated with bariatric surgery, especially with sleeves. It's the #1 reason people come back to the hospital. And the reason is because when your stomach's that small, it's hard to keep yourself hydrated. Usually you come in, you get some fluid, you feel better, and we can send you back home. The number one reason people get readmitted is nausea and vomiting. So after this surgery, about 14% of people nationwide will get readmitted with nausea and vomiting. Our rate here is much lower than that, somewhere around 3%. We try to make sure that we control your nausea from the beginning. We make sure that you go home with plenty of medicine to help control your nausea. And we work aggressively to make sure that we're in contact with you, especially early on, so that we can treat anything that comes up before it requires you to come back to the hospital. Now, less frequently, you could see hernia development anytime you have any sort of abdominal operation. I'll tell you, as a hernia surgeon, it's very rare to see anybody who's losing weight, who doesn't smoke, develop a hernia after an operation. You can get chest pain, especially the night of surgery, just from where we have to work to get that staple, the portion of your stomach out. They can make it feel like there's chest pain there. Now, we work it up and we're very careful about it, but that's just part of having this operation. Gallstones certainly can form anytime you have rapid weight loss, but it's rare. And if it does come up and your gallbladder is giving you trouble, it's no trouble to go in and take your gallbladder out even after this operation. You could certainly have some gastrointestinal inflammation or swelling. Usually we see this very early, maybe the first 24 hours. Occasionally, maybe 2 to 3% of the population will have to stay an extra night in the hospital just to allow some of that to go down. So if 80% of the people lose 80% of their excess body weight, then what about the other 20%? What about the other 20% who aren't as successful? I wish I could tell you who that's going to be. I wish I could tell you that everyone's going to lose weight. But I can tell you, as a bariatric surgeon, we've never developed an operation that's 100%. I can only assure you that if you keep coming to your appointments, even after surgery, if you keep working with our team, with Lisa, our dietitian, and you put in the work to try to make sure that you're doing what we ask you to do, then your chances of success are going to be very high. So how do we know if surgical weight loss is right for you? Well, the first thing to do is figure out what your BMI is. There's BMI calculators online that you can find. There's one on our St. Clair website. If your BMI is above 35 and you have some of those comorbidities we talked about, like high blood pressure or type 2 diabetes, obstructive sleep apnea, or if your BMI is above 40, even if you don't have that, because like we said, that's a red flag, then you're a candidate for this operation. You have to be willing to quit smoking, not just for this operation, but forever. I'd like to tell you that it's because I don't want you to die of lung cancer, which is certainly true, but the real reason is because smokers don't heal. And if you can't heal this staple line, your risk of a leak is higher. But it's also because this is to make you healthier. And smoking's not part of a healthy lifestyle. And so we ask you to stop smoking, not just for this operation, but forever. This is a permanent lifestyle change. This is a tool to help you get where you need to be, to help you be healthier, to help you live longer. You have to be healthy enough to undergo a major operation. I don't expect you to know whether that's you or not. I'm a doctor, that's what I'm here for. And so when we see you in clinic, that's what we're going to help you decide. We want you to at least have attempted to lose weight in the past. Whether that's been a diet that you haven't been successful with or a diet that you're very successful with, but you gain the weight back. It shows us that you're dedicated to trying to play a role in your weight loss. We don't want you to have any current drug or alcohol problems. We don't want you to have any current psychological conditions that are untreated. Now, if you've had drug or alcohol problems in the past, and they're in the past, that's okay. If you have bipolar or you have anxiety and depression, and whoever helps you with that thinks you're in a good spot for bariatric surgery, then that's okay as well. You can't have had an incompatible surgery. And the most common one we talk about is called a Nissen fundoplication. And a Nissen fundoplication is an anti-reflux operation that people have for reflux. It's the way we do that operation precludes us from doing a weight loss operation on you. The risks are just too high. And so unfortunately, we haven't figured out a technology to help with that. You have to be able to understand surgery and its risks. And what I mean by that is that you have to be at least 18 and you have to be able to understand what the consent process is. So you have to have your own decision-making capability. And finally, it can't just be up to me. I always say that the last person you want to ask if you're going to have surgery is a surgeon, because we're biased. We're going to say, yeah, of course you need surgery. But I put together a multidisciplinary team that includes Jessica, my nurse, and Lisa, our dietitian. And we get together and we talk about patients. And we talk about, do you keep your appointments? How are you at making changes that we ask you to make? And we come together as a team and we say, yes, this person is right for bariatric surgery, or no, this person isn't. And everybody gets a vote. So it's not just me, it's the whole team that you have to prove to that you're a good candidate for this. Well, I wish I could tell you we would do it for free. I certainly would do it for free. The hospital would probably frown on that though. But we do work with insurance companies. About half of the private insurers out there will have coverage, and we'll help you figure that out. Most Medicare and Medicaid do cover this operation. If you don't have coverage, we certainly offer a cash price that's probably the lowest in the country. And if you need help with financing, we use Prosper Healthcare Lending, which is a group that you could go to get a loan to help pay for surgery, similar to like Accredited. And again, we're here to help you with that. So, that's really what we do, and that's how we do it. I thank everybody for logging in tonight. I know this is kind of weird, it's certainly the first time I've ever done a Facebook Live, but I appreciate it. We'd love to see you in clinic. If you have questions, we invite you to contact us. You could call us at 606-356-4814, and that goes to Jessica, my coordinator. And you can leave a message. We'll get back with you. We're usually in clinic Mondays, Wednesdays, and Fridays. If you have questions, you can send them in through the Facebook site, and we'll be happy to answer those. But again, thanks for logging in.